9. Will disruptors save the health economy? Anything you can do, I can do better. From Annie Get Your Gun, song by Irving Berlin. The lure of profits is a siren call to innovators. 50 years ago, General Motors was the largest and most profitable business in the world. Enter Honda, Toyota, and Nissan, whose lean manufacturing techniques revolutionized car making and made a mockery of GM's high costs and uneven quality. Or consider Kodak, which once sold more camera film than all other companies combined, until digital cameras turned it into a dinosaur. And then there is Toys R Us, the poster child for all the big box stores that lost out to online retailers. Virtually every industry is replete with stories of once dominant firms cut down to size by innovative competitors. Healthcare is the big exception. One is hard-pressed to find a dominant provider or insurer that started less than 75 years ago. The Blues, Kaiser, Johns Hopkins, Mayo, New York Presbyterian, and Massachusetts General are among the most obvious exemplars of endurance. From coast to coast, yesterday's dominant healthcare organizations are today's dominant healthcare organizations. There are a few relative newcomers like United Healthcare, Sutter, and Intermountain, but even they are 40 years old. This seems very puzzling. Strategy gurus preach about how inefficient firms are ripe for disruption. So where is the disruption in healthcare, whose providers and insurers seem rife with inefficiency? Recent surveys of healthcare leaders suggest that certain sectors of healthcare, hospitals, information technology, primary care, pharmaceuticals, and payers, are desperately in need of disruption. One change does seem to be in the air, with organizations at the periphery of the health economy attempting to take center stage, while successful firms outside of healthcare place seemingly bold bets that they can turn around this broken system. If only it were so easy. The US health economy is a stubborn thing, and we are pessimistic about the potential for outsiders to transform it. Destruction and disruption. The theory of disruption stems from Joseph Schumpeter's discussion of the gales of creative destruction in his 1942 book Capitalism, Socialism, and Democracy. 2 Schumpeter argued that innovative entry by entrepreneurs sustains economic growth while destroying the value of incumbent firms. Although today's business leaders may be unfamiliar with Schumpeter, they are very aware of the concept of disruptive innovation. 3. This term was coined by the late Harvard Business School strategy guru Clayton Christensen, originally in The Innovator's Dilemma, 1997, and then in his application to healthcare, The Innovator's Prescription, 2009. Most people familiar with the concept know that it refers to new approaches with the potential to create or transform an industry. What they don't often recall is that Christensen's disruptors start off by offering bottom-tier products that are cheaper and of inferior quality. They target the low end of the market that has been underserved or not served at all. Left alone by the large incumbents, the disruptors grow market share, allowing them to further reduce costs through scale economies and improve product quality through learning by doing. The disruptors move up the value chain and attack the next lower-tier product market, eventually and successfully challenging the large incumbents in the higher end of the market. In a 2000 article published in the Harvard Business Review, Christensen and his colleagues asked the question, will disruptive innovations cure healthcare? The cure he proposed was the iron triangle of healthcare: improved access, lower costs, and higher quality. 17 years later, Christensen and colleagues published a report titled How Disruptive Innovation Can Finally Revolutionize Healthcare, emphasis added, in which the ever-optimistic Christensen admits that disruption in healthcare, to quote Bob Dylan, is a slow train coming. Over time, Christensen proposed a succession of possible disruptors. Initially his list included retail clinics, ambulatory surgery centers, ASCs, and single specialty hospitals. These all failed to disrupt, for a variety of reasons. 5 More recently, Christensen identified the following likely suspects: diagnostics, Kaiser-like models of integrated care, home-based care, care teams, health coaches, community health workers, and even Medicare Advantage plans. Not only is the train slow, but the train cars, like the Times, are a change in. This chronicle suggests the need to rethink the potential for outsiders to transform healthcare markets. Think of it as the disruptor's dilemma. It would look very different from the innovator's dilemma, because while Christensen's disruptors initially target the low end of the market, it is hard to see how this would work in healthcare. As the economist Mark Pauly succinctly put it, we're not quite as good, but we sure are cheap is not likely to win over the average patient. 6 It almost sounds like an invitation to get sued. Nor does this sound like the approach taken by the new entrants profiled below. While some of these newcomers may try to disrupt healthcare markets, they are not following Christensen's prescription. Nor do we think they are likely to succeed. A different paradigm. In many ways, Christensen's view of disruption runs counter to two fundamental economic principles. The first is associated with the school of thought in corporate strategy known as the resource-based view of the firm. The second is associated with the make or buy problem. When we view potential disruptors through these economic lenses, the reasons for the healthcare disruptors dilemma come into focus, and the few meaningful changes truly stand out. We discuss these principles here, and then use them to assess several of the most highly publicized attempts to disrupt the market. According to the resource-based view of the firm, no firm can outcompete its rivals unless it possesses unique resources and capabilities. Amazon disrupted traditional retailing through a unique combination of a user-friendly online interface and sophisticated distribution logistics. Facebook disrupted traditional advertising through software that keeps users' eyes glued to their screens and by creating highly differentiated, customer-specific messaging. Many of today's so-called disruptors in healthcare do not bring new resources and capabilities to the table. Instead, they reorganize existing resources through mergers and acquisitions of previously independent firms. As we will discuss, this makes it likely they will remain niche players. In a $3 trillion market, even niche players can generate outsized financial returns, but they are unlikely to transform the health economy. The decision to merge or remain independent is known as the make or buy problem, in which make means do it yourself and buy means doing business through market transactions. The economics of the make or buy problem suggest that make is the right answer under very limited conditions. These include 1. The presence of several firms in the value chain, each with some degree of monopoly power, which often leads to inefficient pricing. 2. The existence of severe coordination problems in production that cannot be resolved by contract. Or 3. The need for firms to make upfront investments whose value is contingent on maintaining their relationships with specific trading partners. In the latter case, firms may be reluctant to make these investments out of fear that their trading partners will extract all the profits. While any of these conditions might justify integration, there is an offsetting benefit to remaining independent, namely, that independent market specialists are often more efficient than integrated firms. This is because independent firms face harder-edged financial incentives, ask any entrepreneur, and because independent firms often develop specialized expertise to serve multiple customers upstream or downstream that larger firms find hard to match. With these ideas in mind, we now examine some of the most prominent recent attempts to disrupt healthcare markets. The 2,400-pound upstart gorilla. In January 2018, Jeff Bezos, Warren Buffett, and Jamie Dimon announced a joint venture among their firms Amazon, Berkshire Hathaway, and J.P. Morgan Chase, which they referred to as ABC. Its stated goal was to find ways to control costs and improve the quality of healthcare offered to their 1 million employees and dependents. Although many observers of the healthcare sector hailed these business leaders as saviors, Bezos et al. Stressed the need for patience. They had no idea how to effect meaningful change, they only knew that they had lots of money and the determination to change the status quo. They made a good start in June 2018, when they tapped the physician and Harvard professor Atul Gawande to be CEO of their joint venture. Gawande's books and articles in The New Yorker and elsewhere have drawn attention to many of the problems facing our healthcare system. Point 7. He recognizes that physician decision-making is at the heart of the crisis, however, he has sometimes been a cheerleader for large hospital systems. 8. 3 years in and there is little to report, other than that Bezos, Buffett, and Dimon named their venture haven ostensibly to signal to employees that this is their new home, one that will explicate the intricacies of healthcare and health insurance. One immediate goal was the redesign of health insurance benefits for their own employees. Amazon and J.P. Morgan would offer new plans to employees in 2020 that feature wellness incentives, no deductibles or co-insurance, flat copays, and out-of-pocket maximums. Berkshire tested a similar pilot in a few of their companies. The plans would be administered through the major MCOs, example Cigna, Aetna. ABC hired Dana Safran away from Blue Cross Blue Shield Massachusetts to help. If they were going to disrupt the industry, they needed to do a lot more than this, and they knew it. Other espoused goals included making it easier to access primary care, making it easier for primary care doctors to provide good care and spend more time doing it, and making pharmaceutical costs more affordable. Point 9. This sounds like just another way of saying that they want to solve the iron triangle. Who doesn't? The leaders of ABC suggested they had more ambitious long-term plans to address the iron triangle for the country, not just for their employees. What could one expect from the ABC initiative? We start by asking what resources and capabilities ABC brought to the table. Special expertise in understanding how to influence physician decision-making? While Gawande was no slouch, he had no unique insights. Innovative information technologies? No. New approaches to data science? Again, no. To us, it smacks of the hubris shared by many managers who believe that past success in one industry guarantees success in others. The idea that great managers have some sort of Midas touch is the stuff of legend. In the real world, however, success in one area does not guarantee success in another, no matter how deep the pockets. ESPN sold a mobile phone called the Mobile ESPN. Microsoft once offered the Zune, and Google released a game called Lively. Removed from their comfort zones, these successful firms all found ways to fail. Don't get us wrong, ABC possessed many resources and capabilities that conveyed powerful advantages in its native markets. No one is better than Amazon at distribution and cloud computing. J.P. Morgan Chase excels at selling financial instruments while navigating financial regulations, while Warren Buffett has been a preternaturally good stock. The problem is that ABC lacked the expertise required to transform healthcare delivery. None of its principals had experience managing healthcare professionals or dealing with customers at the height of emotional engagement, which is what it will take to fix the doctor-patient relationship. Nor did Dr. Gawande have any meaningful management experience. Collectively, these executives might provide new insights into how we use data, but it is not as if they were inventing the wheel. Many industry analysts argue that they would come up with solutions by thinking outside the box. With healthcare consuming nearly 20% of GDP, there are already thousands of entrepreneurs doing just that. To their credit, the three business superstars acknowledged that the healthcare system is enormously complicated, echoing President Trump, that fixing it was not going to be easy, and that we should not expect any miracles out of us soon. 10. This is not the first time that firms which have enjoyed massive success in other industries have made forays into healthcare. Their track record is not reassuring. Microsoft Vault's and Google Health's failure with personal health records come to mind. Google is giving it another try, by entering a joint venture with mega provider Ascension Health. Whether this will allow Ascension to use Google's data analytics to improve care delivery, or whether Google will use Ascension's patient records to better target advertising, remains to be seen. ABC should have been cautious. Amazon does possess one potentially valuable capability, which it may use to disrupt retail pharmacy. In June 2018, it purchased PillPack, an online pharmacy startup. With Amazon's considerable expertise in home delivery, imagine drones dropping off pills at your door. This seems like a logical extension of its business model. Investors took note, as shares of retail pharmacy giants CVS and Walgreens plunged 10% after the deal was announced. Investors quickly determined that there was less here than met the eye, as Amazon has no obvious plan for turning PillPack into a mainstream competitor. By August 2018, CVS and Walgreens were trading at or above their all-time highs. Amazon may soon use PillPack as an online supplier to its own employees. It remains a long way from threatening the retail pharmacy giants. Even if Amazon successfully disrupts retail pharmacy, it would make little more than a dime's worth of difference to the overall health economy. Pharmacists have little input into medical decision-making, and online pharmacies have almost none. Smart technology and big data may allow pharmacies to identify drug use patterns suggestive of health problems, and might flag these for physicians. Walgreens and CVS are already doing this, as we discussed below. If Amazon does the same, the benefits to consumers will be incremental at best. Given Amazon's business model, it seems equally likely that Amazon will use big data to improve how they market and sell other goods. Just imagine filling a prescription for a cholesterol blocker and then finding that Amazon sends you advertisements for diet books and exercise equipment. Not everyone will think this a boon. We would be remiss if we did not mention one other resource that ABC possessed in great supply: cash. This means that it could afford to lose massive amounts in new ventures. And we can never rule out succeeding through dumb luck. If you play the lottery often enough, you might hit the jackpot, even if the odds are heavily stacked against you. As this volume goes to press, we can conclude the story. Haven's early history was rocky. In its first 3 years of operation, it saw the turnover of its CEO, Atul Gawande, its chief operating officer, its chief technology officer, and its data scientists and software engineers in all, about 14% of the workforce with public profiles on LinkedIn. The CEO said he wanted to spend more time on policy and advocacy work, example in relation to COVID, perhaps not too surprising, given that he never left his academic position at Harvard. Haven's ambitions to shake up health insurance likely exceeded its ability, especially given the geographic dispersion of the 3 founding companies' workforces, the lack of any concentrated presence of these employees among any set of providers, and the numerous stakeholders in the U.S. healthcare ecosystem that they would need to engage. It also did not help that Amazon has pursued its own provider initiatives, example virtual care. In January 2021, ABC shut down altogether, disrupting the lives of its remaining 50-plus employees. Smaller newcomers. While ABC entered the fray with deep pockets, many smaller companies hope to disrupt the market by exploiting modern technology. One of the most interesting is a newcomer to the insurance market. Others are small companies that hope to change the healthcare world one web app at a time. And who goes to Oscar? Oscar, which bills itself as a new kind of insurance company, wants to do for health insurance what Geico and Progressive have done for car insurance: sign up millennials over the internet with little hassle and at a low cost. Founded in 2012, Oscar has more than 400,000 members as of 2020, and was valued at more than $3 billion. It started in New York and has expanded to nearly 20 states including California, Florida, and Texas. Some of our MBA students think it is the next big thing. If only they could articulate why, especially since most of Oscar's growth comes from geographic expansion, with relatively modest within-state growth. With its heavy reliance on ACA exchange enrollments, Oscar has been blindsided by the repeal of the individual mandate, which reduced the appeal of the individual market. With ongoing losses, $131 million in 2017, $57 million in 2018, Oscar is now moving into the crowded Medicare Advantage and small business markets. By all appearances, Oscar's online platform makes all the other health insurers seem very 20th century, providing an experience that works well for its targeted audience. Oscar boasts the highest member engagement of any insurer. Unfortunately, Oscar's positioning strategy, to the extent it has one, pretty much stops there. Oscar does not do anything else particularly well, and in most important respects it remains at a deep disadvantage relative to the competition. As a result, it is likely to remain a niche product. We are skeptical as to whether Oscar will ever remotely resemble United Healthcare, the last great startup insurer. Why such skepticism? Think about the tasks performed by traditional insurers. They employ actuaries and underwriters to estimate risk and price it. They assemble networks. They adjudicate claims, analyze data, and manage care. They offer wellness and disease management programs. The best insurers work proactively with providers to reduce costs and boost quality. They have dedicated sales forces that sell to and service the needs of employer groups. What does Oscar do? Other than marketing on the internet, not much. It rents its broad networks from other insurers, which immediately puts it at a cost disadvantage. To offset this, Oscar has begun forming its own narrow networks. This allows Oscar to get reasonable discounts as well as funnel care to low-cost providers. Young and healthy enrollees, especially those who rarely engage in the healthcare market, do not mind these choice limitations. Small businesses looking for cheap health insurance solutions might also buy in. Midsize and large employers, which account for the bulk of commercial insurance enrollments, will steer clear. Oscar also outsources care management and wellness, again driving up its costs. And despite its high-tech image, Oscar lacks the sheer volume of data, let alone the data analytics capabilities, to match those of its bigger rivals. Again, this might not matter to its core market, but it necessarily limits the size of the core. Is it any wonder that Oscar largely thrived on the ACA exchanges, whose participants skew young, healthy, and inexperienced as healthcare consumers? Oscar has room to expand its model to more states, but is unlikely to achieve substantial market penetration in any of them. This quote from a dissatisfied customer posting to bestcompany.com sums up Oscar's problem. Oscar has some nice bells and whistles for millennials: a phone app, a decent website, a wellness center in Brooklyn. None of this is a substitute for good coverage, which they definitely do not offer. 11. Oscar is hardly the only insurer that steers away from the employer marketplace. Centene, Molina, Neighborhood Health Plan, Amerigroup, and others have all fared well in the exchange and in Medicaid managed care markets with plans that often feature narrow networks with few bells and whistles. Executives at the Blues, United, Aetna, or Cigna do not lose any sleep over them. Oscar partnered with Cleveland Clinic on a co-branded health plan, launched in 2018, to offer individual coverage to 5 counties in Northeast Ohio. Enrollees get access to Cleveland Clinic primary care physicians and care managers, as well as an Oscar concierge nurse and 3 care guides, and 24/7 access to telemedicine. The plan enrolled 11,000 members for 2018 and is now engaged in rolling out to additional counties in Ohio. Oscar also announced partnerships with both Humana and Cigna to provide services to small business owners. Essentially, Oscar can bring its technology-enabled healthcare services to small businesses in concert with the large healthcare networks that employers are used to working with. For 2020, Oscar plans to expand into 19 new markets and 4 new states, which would bring its total footprint to 47 markets in 19 states. Part of the expansion will rest on Oscar's virtual primary care, which offers digital and in-home services, example lab draws, at no cost in selected markets to respond to the COVID-19 crisis. Oscar faces stiff competition in all the new markets it is trying to enter. Medicare Advantage, MA, is an increasingly saturated market, with an estimated 2,700 MA plans open for enrollment in 2019. This is 18% higher than the 2,300 offered in 2018. Over the same period, MA enrollment is projected to grow 11.5%. If growth in new plans continues to outpace growth in new enrollees, Oscar may struggle to grab any market share. Oscar also has to compete with the largest insurers, which account for a large share of MA enrollees and have disproportionate underwriting gains. Oscar may not find the small business market any easier, given the large number of players. Ultimately, Oscar envisions a healthcare industry where employer-defined plans will disappear as more consumers turn to individual coverage (HDHPs) and health reimbursement arrangements (HRAs). From a small base of only 70,000 enrollees several years ago after retrenchment and withdrawal from several markets, example Dallas, New Jersey, Oscar Health has grown to roughly 400,000 enrollees, including around 375,000 individual members and another 20,000 coming through small group insurance and Medicare Advantage. Fueling this expansion is a massive capital infusion of $540 million raised from Alphabet, Founders Fund, Capital G, Alphabet's later-stage investment firm, and Verily, Alphabet's investment firm focused on life sciences. Overall, Oscar has raised $1.3 billion, with plans announced in December 2020 to file for an initial public offering. What app, Doc? Every year, a few of our MBA students believe that the path to reforming the healthcare system goes through their smartphone. They want to use big data and little phones to facilitate price shopping, allow patients to self-diagnose every sort of ailment, track physical activity, and send real-time reports to nurses at monitoring stations, who can send feedback to the users, alert primary care physicians, or even call for an ambulance. Another set of apps creates a video interface between patients and doctors, while allowing both to access the patient's medical history. This cross between Skype and electronic health records allows patients to obtain urgent care without leaving home, a virtual return to the good old days when doctors made house calls. The field is very crowded. A 2016 study reported more than 250,000 available consumer apps for dozens of medical conditions. Point 12 However, there is very little regulation and quality control in this space. The U.S. Food and Drug Administration has vetted only a fraction of a percent of the mobile apps available. There are also concerns over security of the private information conveyed through these apps, an issue rarely addressed in consumer written reviews. Despite this, many of these ideas are catching on. Even more concerning is the evidence base on mobile apps. A 2018 study identified 23 randomized trials evaluating 22 available apps that mostly address diabetes, mental health, and obesity. Point 13 Most trials were pilot studies with small sample sizes and limited durations. While 11 of the 23 trials showed a meaningful effect on health or surrogate outcomes attributable to apps, the overall paucity of evidence showing app effectiveness makes it difficult to be confident about their future. We see several reasons why smart technology will have limited impact on mega providers. The first two are related to the 80-20 rule of medicine, also known as the Pareto principle. 80% of spending can be traced to 20% of the population. Patients with cancer, on dialysis, or in need of joint replacement surgery will have little to gain from these new technologies. This is backed up by a recent study of 20 digital health companies with more than $2.5 billion in private equity funding. Point 14 The study found a total of 156 published studies on these companies' products. Of these, only 29 studies pertain to high-burden conditions such as cancer, stroke, or heart disease. Even these products may have a hard time reaching their target audience, which consists mainly of older patients who, at least for now, are less tech-savvy and are unlikely to replace the traditional doctor-patient relationship with the impersonal cell phone. Ultimately, the key question is whether smart technology will substitute for or complement the traditional provider-patient relationship. While many patients may want to participate in medical decision-making, we suspect that few will want to be their own doctors. Direct contracting. If big insurers face a non-regulatory threat, it may come from their biggest customers, who are directly contracting with providers. The most prominent of these is Walmart, which caught everyone by surprise in 2012 when it announced a Centers of Excellence program to serve its own employees. Walmart offered to cover 100% of medical costs, plus travel expenses, for selected spine and cardiac surgeries performed at one of 6 selected health systems across the country, including the venerable Mayo and Cleveland clinics. Walmart has since doubled the number of participating providers. It only pays for spine surgery at its Centers of Excellence, and may tidily narrow its networks for other procedures. Walmart does not disclose the prices it pays to these systems, but it seems likely that it is getting a pretty hefty discount. It also claims that its designated providers avoid unnecessary procedures, and when they do perform surgery, they are delivering better outcomes, which gets Walmart's employees back to work sooner. Walmart also directly contracts for diagnostic services, paying for some employees diagnosed with cancer to fly to the Mayo Clinic in Rochester, Minnesota. Walmart reports that 10% of employees referred to Mayo had been incorrectly diagnosed by their local providers. Thanks to Mayo, these employees receive more appropriate and usually less expensive treatments. This does not imply an overall false positive rate of 10%, as only selected employees make the trip to Mayo. Walmart has expanded this program to a half-dozen centers of excellence. Through its Centers of Excellence programs for surgery and diagnostics, Walmart is doing exactly what had made it so successful as a retailer. It is bypassing the middleman and contracting directly with suppliers. Walmart is not the only big company involved in direct contracting. In a 2018 survey of some of the nation's largest employers, 18% said they expected to directly contract with hospitals. 15 A broader survey found that 6% of large employers were directly contracting with hospitals and an additional 16% were considering it. 16 The most popular procedures for direct contracting included transplants, bariatric surgery, and spine surgery. Despite this trend, we doubt whether direct contracting poses an existential threat to big insurers. Simple economics seems to weigh against direct contracting. For most things it sells, Walmart is its supplier's biggest customer, which allows it to negotiate the best deals. This is rarely the case for medical care, where Walmart is hard-pressed to match the purchasing clout of a local Blue or United plan. 17 Walmart succeeds here by tightly narrowing its network, usually just a handful of providers across the entire nation. This allows it to drive market share and command larger discounts. Only a handful of large employers will be able to copy Walmart before overwhelming Mayo and the other top centers. Future success will require narrowing networks within local geographies rather than concentrating patients in just a few national centers. Thus far, most employers seem reluctant to offer narrow local networks. Direct contracting is also largely restricted to a handful of discrete surgical procedures, as well as some diagnostic procedures. This is no accident. It is fairly easy to negotiate a price for bariatric surgery, which involves a relatively fixed and predictable bundle of services and lends itself to a fixed bundled price. It is far more difficult to identify a common bundle of services for patients with chronic conditions or with conditions, such as cancer, whose course is difficult to predict. This makes bundled pricing all but impossible for many costly conditions. When it comes to direct contracting, the size of the purchaser matters. The more covered lives in the contract, the bigger the discount, and even modest-sized insurers control more covered lives than all but the biggest employers. Many insurers offer narrow networks for the selected surgical procedures, and for every large employer that directly contracts with providers, there are 4 that rely on insurance-sponsored narrow networks. 18 Even if more employers choose to go the narrow network route, it will still be more economical for insurers to offer them. By combining the purchasing clout of their many clients, insurers will be able to strike better deals, and perform more effective care management, than even the largest employers. Making new connections. Another potential source of disruption comes from new combinations of existing firms, many of which possess ample resources and capabilities that support their current success. Will integration lead to further success, or just a rearrangement of the deck chairs? As our discussion of the economics of make or buy suggests, there are often complex economic factors on both sides of the ledger. Drugstores, insurers, and pharmacy benefit managers. In December 2017, CVS Caremark announced its merger with Aetna. 4 months later, Cigna and Express Scripts tied the knot. Observers predict big things for both deals. Before we tone down these expectations, we should point out that there is a genuine make/buy efficiency in play. Each deal brings a traditional medical insurer, Aetna and Cigna, and a pharmacy benefit manager, CVS Caremark and ESI, under one roof. Properly designed, health insurance should encourage the proper balance of medical and drug treatment. Patients should not have to face high co-payments for drugs that substitute for more expensive medical care. When drug coverage is divorced from medical coverage, however, pharmacy benefit managers, PBMs, may have less incentive to promote substitution toward expensive drugs, even if the alternative is more expensive medical care. The result is a formulary that reduces drug costs but raises overall treatment costs. Research confirms that when medical and drug coverage decisions are coordinated by an integrated firm, cost sharing is rationalized, and total spending goes down. 19 The benefits of this coordination might be enough to justify these enormous deals. They had better be enough, because it is difficult to find any other surefire efficiencies. We focus on the CVS-Aetna deal, which drew the lion's share of market and regulatory attention. CVS consists of 1. A large chain of nearly 10,000 CVS retail pharmacies, 2. A large PBM, Caremark, with 90 million members, 3. A chain of more than 1,100 retail clinics, minute clinics, that reside within some of its pharmacies, and 4. A staff of 4,000 nursing professionals working in the retail clinics and home health care. For its part, Aetna is a large health insurer covering roughly 22 million enrollees with Medicare Advantage, Medicaid, and commercial insurance. According to a CVS Health statement, the merger will integrate more closely the work of doctors, pharmacists, and other healthcare professionals and health benefits companies to create a platform that is easier to use and less expensive for consumers. 20 In so doing, the combined company will serve as America's front door to quality healthcare. Not quite the Iron Triangle, but close. According to the announcement, the merger will have 13 specific aims. Combine CVS Health's clinical capabilities with Aetna's analytics. Connect Aetna's provider network with CVS Health's community access model. Remake the consumer healthcare experience. Improve understanding of patients' health goals. Guide patients through the healthcare system. It is the triple aim on steroids. Anyone who can deliver on all of these benefits deserves Nobel Prizes for medicine and economics. Thus far, the firms have been a bit vague about how they will meet these goals. At the J.P. Morgan Healthcare Conference in San Francisco in January 2019, CVS's CEO, Larry Merlo, summarized the value proposition in a simple statement: create a uniquely powerful new platform that will enable us to transform the consumer healthcare experience. Aetna's Chief Digital Officer, Firdaus Buttina summarized it even more simply as one-stop shopping, a label also applied by Harvard Business School economist Leigh Daphne. 21 Such labels are designed to conjure up the image and imagined benefits of Kaiser. More recently, Larry Merlo confirmed the primacy of its Health HUB pharmacy store concept during CVS's Investor Day. While there are lots of moving parts here, much of the enthusiasm for this deal rests on CVS's retail clinics, Aetna's claims database, and the espoused belief that data is king in today's economy. These supposed advantages are fraught with problems, as outlined below. 22. Retail clinics. CVS Health operates minute clinics in roughly 1,100 pharmacies. Following the merger, these retail clinics will purportedly become mini health centers that expand access to lower-cost healthcare services and improve care convenience. Some liken them to new community health centers. As we have detailed in earlier chapters, healthcare is local, and there are few firms offering more local options. 71% of Americans live within 5 miles of a CVS. 23 Patients who visit nearby minute clinics will have faster access to lower-level care that can increase earlier management of illness and reduce unnecessary use of hospital emergency rooms. In this fashion, retail clinics will help solve the iron triangle of healthcare by simultaneously delivering on improved access, improved outcomes, and lower costs. Proponents have long hailed the potential for retail clinics to transform the healthcare industry. Such expectations began with Christensen's futuristic view of retail clinics as a disruptive innovation. 24 This helped to propel a rapid rise in the number of clinics that, in turn, led consultants to forecast growth in the sector to nearly 3,000 by 2021. 25 Proponents also claim that enhanced retail clinics can cure many of the ailments plaguing the health economy. We disagree. When viewed through the lens of make or buy economics, it is difficult to see the value proposition in pharmacy-based retail clinics. While it is true that the healthcare value chain is often poorly coordinated, combining pharmacy with primary care seems like an odd way to address the problem. Mega providers, which integrate nearly the entire value chain except for retail pharmacy, have struggled to improve care coordination, so it is difficult to see how pharmacy/PCP integration is going to do any better. Avoiding whole UPS and promoting investments. The other potential benefit of make versus buy seems like a total non-starter. Retail pharmacies offer one real asset: convenient locations for patients who require basic primary care. That will only take the concept so far. Not surprisingly, the hope for expansion in the retail clinic sector has yet to happen. The number of clinics plateaued just below 2,000 sites by 2015, with a slight decline by 2018. 26 The average clinic sees only 10 to 30 patients per day, and loses $40,000 annually. 27 The trend holds for both CVS Health, which operates roughly half of all such clinics, and Walgreens, which operates roughly one-fifth. If anything, Walgreens has shifted its strategy away from in-house clinics to partnerships with local health systems that own and operate the clinics inside Walgreens, effectively moving away from a vertically integrated model to a strategic alliance model. Other retail clinic chains have also stopped their expansion. For its part, CVS Health has concentrated its efforts in recent years on horizontal integration and on transforming the pharmacy operations acquired from Target. Contrary to the hype, retail clinics are not a booming industry. Even one of Christensen's colleagues has admitted this. 28. There are other explanations for the stalled growth of retail clinics. CVS Health's pharmacies have experienced slow overall growth. 29 This may be partly attributable to its efforts to swallow two recent acquisitions, long-term care pharmacy Omnicare, and Target's in-store pharmacies. With top management focused on internal integration issues, CVS would naturally take a go-slow approach to expanding elsewhere. The stalled growth also reflects the maturation of the retail pharmacy business, with annual growth of only 1 or 2%. Retail pharmacies also face mounting competition from mass merchandisers, mail-order prescription providers, online pharmacies, convenience stores, and other health clinics. Indeed, some speculate that CVS plans to use its retail clinics to play catch-up with United Healthcare's Optum subsidiary and its Meet Express urgent care centers. In contrast to retail clinics, the number of these centers grew by 8% between 2017 and 2018. There is some speculation that the retail pharmacy market suffers from excess capacity and that consolidation is likely, due to falling drug reimbursement rates, mandatory mail-order plans, the growth of generic drugs, and the growth of narrow networks. 30 Drug volumes and general margins in retail pharmacies, including CVS Health, remain stagnant at best. 31. CVS also faces competition from Amazon/PillPack. CVS has funded a pilot at 350 of its drugstores in Boston to compete with Amazon called CarePass, which offers free delivery on most online purchases and prescription drugs, a 20% discount on CVS-branded products, 24/7 access to a pharmacist helpline, and a monthly $10 coupon, all in exchange for a $5 monthly or $48 annual subscription. In various cities, CVS is also offering same-day delivery of prescription drugs. This pricing and these benefits are not sustainable. One final problem with CVS's strategy is the issue faced by all firms that seek to vertically integrate, a mismatch in capacity across stages in the value chain. For example, CVS has 135 pharmacies in the state of Minnesota, comprising roughly 10% of that market. It has only 25 retail clinics, indicating that more build-out is required. More importantly, Aetna has a small share of the Minnesota private health insurance market. Thus, the company will be challenged in steering enough Aetna enrollees to retail clinics in CVS pharmacies to keep them busy, and will be required to attract enrollees from rival insurers and PBMs. Analytics and big data. One of Aetna's major contributions to this merger is its analytics capability. CVS Aetna's chief financial officer, Eva Boratto, announced that the merged company will invest up to $350 million in 2019 on analytics and digital capabilities to improve chronic care management and enhance its clinical platform. 32 The goal? to engage enrollees, improve outcomes, and lower costs, shades of the Iron Triangle. In recent testimony, Aetna counsel Thomas Sabatino stated that his company's analytics team can identify members who are at high risk for developing health complications and share that information with providers to help them prevent catastrophic health events before they happen. 33. There is less here than meets the eye. Insurers have been developing predictive modeling capabilities since the early 2000s. Aetna was already a leader in this area. Predictive modeling has had limited success thus far, and it is not clear how an additional $350 million will make much of a difference. The problem is that prediction is not enough. Even if CVS Aetna can identify high-risk individuals, it must 1. Contact and alert them, 2. Activate them to seek care, and 3. Change their behavior to prevent further complications. The problem here is that those at highest risk are among the least motivated to take care of their own health, and may also be least able to take corrective action. It is not clear how Aetna's linkage to a chain of pharmacies, some of which have retail clinics, will ameliorate this situation. There is also growing recognition of the oversell of digital health technologies. A recent issue of Health Affairs is devoted to this topic. 34 There is scant evidence of clinical impact on any of the corners of the Iron Triangle. Moreover, most digital companies do not seem interested in studying the impact of their technologies on clinical endpoints. This may reflect the fact that technologies that work in a laboratory setting have trouble working in the real world, as Google has discovered in its effort to apply artificial intelligence to treating blindness in India. 35 While algorithms can be trained on sample images, real-world photos of patients' eyes can be a whole different ballgame. The same may prove true for all sorts of conditions. Like retail clinics and digital technologies, the whole field of healthcare analytics has suffered from excessive hype. Big data requires big analysis and big understanding to test hypotheses about what the data suggest and to discern signal from noise. We can use big data to identify associations, and we can apply machine learning for predictive modeling. These are valuable tools, as they allow us to make informed guesses about which patients are at risk for what outcomes. This is the starting point for positive change, but more must be done. As noted by John Halamka, Chief Information Officer at Beth Israel Deaconess Medical Center, someone has to ask the right questions. 36 What big data does not easily allow us to do is make causal inferences so that we can understand how to improve outcomes. Consider patients who are at risk for heart disease. Thanks to big data, we are better able to identify these patients. Once we know who they are, we might want to encourage them to change their diets and exercise regimens. The question is how. Should we provide patients with more information about their health? Nudge them with reminders to exercise? Incentivize them? Inform their physicians and let them do the nudging? To answer these questions, we need to figure out what causes what, something all the terabytes in the world may not tell us, though a carefully designed randomized trial of just a few dozen patients might. Even if we come to these deep understandings, we have to get patients and physicians to buy in. Can Aetna achieve buy-in where integrated healthcare systems have failed? It is definitely worth the effort, even if we are skeptical of its success. Progress is slow. Recent research shows that predictive analytics using a claims-based algorithm to compute member healthcare utilization risk scores can help in the treatment of high-risk elderly patients with chronic conditions. 37 Such targeting can reduce some types of utilization, specialist visits, emergency room visits, but not the most expensive types of utilization, hospital admissions. The impact here is due more to care coordination for the chronically ill rather than to the artificial intelligence technology, however. In other words, AI helps identify patients who need help, but old-fashioned personal attention is required to deliver that help. Thus, any new technology may owe its impact to the accompanying social structures to help implement them, a fact long ago observed as the socio-technical system. It's not certain that the new tech entrants understand this. Based on the growing isolation of younger Americans, it appears that social media companies emphasize the technical side more than the social. Nearly 2 decades after the introduction of electronic health records, there is no evidence that big data is reducing costs, and only scattered evidence that quality of care is improving. 38 A more recent illustration of such overblown expectations is IBM's aggressive promotion of its Watson supercomputer as a revolution in precision medicine and cancer care. Analysts suspect that IBM marketed the product to providers without any evidence base, in order to bolster its flagging revenues. 39 We might summarize this critique by reminding everyone that, like AIRS, artificial intelligence and big data are tools and not solutions. 40 Tools do not transform companies, let alone industries. Other rationales for the deal. When the ESI/Cigna deal was announced just months after CVS Aetna, any informed observer of the healthcare industry should have immediately asked, why them, why now? One cynical answer was that the Department of Justice had just blocked horizontal mergers of Aetna and Humana, and of Anthem and Cigna. Given the well-known adage that public companies need to show growth to their investors, the two health insurers looked to other companies with which they might merge and thereby boost their earnings. What gives credence to this cynical view is that within 1 month of a U.S. district court blocking its merger with Aetna, Humana courted the nation's largest post-acute care provider, Kindred, a deal consummated in June 2018. Another explanation for the CVS-Aetna merger is that it is a defensive strategy undertaken by both parties. Many suspected that CVS Health moved on this deal to counter Amazon's entry into pharmacy distribution. In hindsight, this rumored entry did not occur. Moreover, CVS Health has been facing declining performance over the past few years, in part due to a loss of pharmacy customers to Walgreens. In 2014, Walgreens formed a strategic alliance with Prime Therapeutics, the PBM serving Blue Cross Blue Shield plans in several states. As a result of this alliance, BCBS members were steered away from other pharmacies, including CVS, and toward Walgreens as their national preferred pharmacy network. For Aetna, the merger may be a defensive move to counter growth challenges. Much of the growth in managed care enrollment has occurred in 3 market segments: Medicare Advantage, Medicaid, and, until recent years, the state health insurance exchanges. Aetna had lower market share in the more profitable Medicare Advantage market, and sought to correct that weakness through its proposed 2016 merger with Humana. Aetna was looking for growth in all the wrong places as the Department of Justice successfully blocked the merger. Aetna also watched as the Optum Health subsidiary of its major competitor, United Healthcare, announced in December 2017, the same month as the announced CVS-Aetna deal, its plan to merge with a large provider, the DaVita Medical Group. The deal would add significant physician capacity. DaVita has 300 clinics with a reported 13,000 affiliated physicians, to Optum's burgeoning provider network, 30,000 physicians, both employed and affiliated, serving its MA plans. It would also augment its large ambulatory care business. DaVita has 35 urgent care centers. United already operates 250 Meet Express urgent care centers and a chain of surgery centers. Aetna is thus looking to respond to the growing provider presence of a major competitor. We will leave it to the financial analysts to explore the benefits of growth for growth's sake, although we suspect they are not pleased. We will observe that this seems a lot more like rent-seeking than value creation. There may be some benefit to CVS-Aetna, but where is the benefit to the health economy? The antitrust wrinkle. Some critics of the CVS-Aetna merger complained that it represented a further concentration of power, and asked for antitrust relief. For example, the American Medical Association opposed the deal on the grounds that it would lead to excessive concentration in Medicare Part D and PBM markets. 41 The Department of Justice took nearly a year to review the merger, during which time market analysts questioned whether it would go through. They need not have worried, as the antitrust concerns were overstated. The two firms overlapped in a few markets, and the DOJ did require Aetna to divest its Medicare Part D drug insurance business as a condition for approval. There was also some concern about vertical aspects of the deal, namely that Aetna might tailor insurance benefits and provider fees to favor CVS Minute clinics, while CVS might raise its Minute clinic prices to other insurers, so as to favor Aetna. The DOJ looked long and hard at this raising rivals' costs argument, but took a pass. The DOJ may have felt that neither Aetna nor CVS Minute clinics had the market size necessary to make the theory plausible. Critics also protested that Aetna would push enrollees to visit CVS clinics. This would be a product feature or product defect, depending on one's point of view, and not an antitrust violation. If consumers didn't like it, they could choose another insurer. What probably cemented the DOJ decision to approve the deal was that U.S. District Court Judge Richard Leon, who was hearing the CVS-Aetna case, had just ruled in favor of the AT&T/Time Warner merger. The two deals have similar economics, especially the raising rivals costs argument, with the facts favoring CVS-Aetna at least as much as AT&T/Time Warner. Surprisingly, after the DOJ allowed the deal to go through, Judge Leon raised new questions concerning the growth of CVS's PBM, at a time when the U.S. Senate was looking into alleged anti-competitive practices of the PBM sector. Walgreens has a go at it. Not to be outdone, CVS's major competitor, Walgreens, has entered the fray. In mid-2018, Walgreens launched a digital marketplace in partnership with 16 local health systems and national providers. The website FindCare now lists cash prices for a range of healthcare services. This is hardly a new idea. Led by the late Uwe Reinhardt, academics and policy wonks have been calling for healthcare price transparency for years. 42 Many private insurers offer transparency tools, as have a handful of entrepreneurs whose smartphone apps give prices for everything from prescription drugs to MRIs and ultrasounds. The problem is that no one has figured out how to consistently translate price transparency into lower health spending. 43 Individuals who use price transparency tools tend to be young and healthy, hardly the desired target audience if one is trying to bend the cost curve. Users also tend to have big deductibles, which makes sense, but once they exhaust their deductibles, the benefits of price shopping disappear or are attenuated. Someone may yet figure out how to get high-cost patients to respond to prices, but Walgreens' effort does not strike us as the answer. 44. Walgreens is looking for other ways to expand. It is collaborating with McLaren Healthcare to offer new healthcare offerings in its Michigan drugstores, and it has formed a partnership with Laboratory Corporation of America to open 600 medical testing locations in its stores. It announced a partnership with Humana, called Partners in Primary Care, to develop senior health clinics. As noted above, Walgreens has developed a pilot with United Healthcare's Meet Express unit to develop urgent care centers next to its pharmacies with separate entrances, but with a connector between them and the pharmacies. The stated goal, according to David Wichmann, United Health Group CEO, is to develop a higher-performing local health system, whatever that means. 45 In January 2019, Walgreens announced a 7-year pact with Microsoft to develop new care delivery models that leverage Microsoft's Azure Cloud and artificial intelligence platform, including digital health corners in some stores to sell healthcare related hardware and devices. Walgreens is also now working with Microsoft scientists to create the store of the future, and healthcare breakthroughs to be named later. In classic corporate speak, Walgreens' CEO, Stefano Pessina, stated that the strategic partnership with Microsoft demonstrates our strong commitment to creating integrated, next-generation, digitally enabled healthcare delivery solutions for our customers, transforming our stores into modern neighborhood health destinations. 46 He also called the partnership an effort to create a seamless ecosystem of participating organizations, example providers, insurers, and pharmaceutical firms, that will be able to facilitate the life of our customers. We await the translation. Like those of many other would-be disruptors, Walgreens' strategy includes a heavy emphasis on bricks and mortar in the local community. Such an emphasis serves as a contrast to, and hopefully a competitive advantage over, Amazon's more virtual approach. That said, both Walgreens and CVS also emphasize their digital approaches to compete with Amazon. At the same time, Amazon has bought up Whole Foods as perhaps a foothold in the bricks and mortar space, with an option to open even pharmacies or retail clinics in its grocery stores. It may also open thousands of Amazon Go cashierless stores. It sounds like everyone is hedging their bets and moving into one another's spaces. It does not sound as though they have anything new to offer to healthcare consumers, except more places to spend the same healthcare dollars. United's big bet on big data. We have previously commented on the importance and limitations of big data for predictive analytics. United Healthcare has placed a big bet on doing more than just predicting illness. Its spin-off company, Optum, holds the largest private claims database and employs a large team of computer scientists and social scientists to mine the data for all they are worth. While that seems like yet another, albeit large, bet on data analytics, Optum is also the nation's largest employer of physicians. After its recent acquisition of DaVita's medical groups, United employs and affiliates with roughly 50,000 physicians, or about 5% of all physicians in the United States. Optum also owns labs, outpatient surgery centers, and urgent care centers. The obvious question is whether the two strategies, data analytics and vertical integration, are linked. At a minimum, United can assure that its vertically integrated physicians are equipped with the latest AIR technology, something that independent physicians often lack. After mining its data, Optum can also keep its providers informed about the latest discoveries. Optum could even conduct experiments in which some of its physicians employ new treatment options. Optum would be well positioned to rapidly change treatment pathways in response to new discoveries. Optum's vertical integration strategy might ultimately pave the way for discoveries about treatment processes, as opposed to specific drugs or medical procedures that have been out of reach in our fragmented system. Of course, what sounds good in theory often falls apart in practice, as mega providers have discovered. Whether Optum can deal with physicians as effectively as it deals with data remains to be seen. Still, this seems far more promising than merely amassing terabytes of medical records. Optum has one other reason for buying up providers in the value chain that may be more about rent-seeking than about value creation. These acquisitions give United leverage when bargaining with powerful providers, including some of the mega providers we have profiled. Optum could also use its data analytics capabilities to experiment and identify ways to steer enrollees to the lowest cost treatment options. Pushed to the limit, this might mean that United enrollees are steered to United providers. In this way, United may be on its way to being a Kaiser with a national scope, albeit without Kaiser's culture or deep knowledge about how to work with physicians to manage patient care. If this is all that Optum ultimately accomplishes, it will serve United's interests, it may serve the interests of United's enrollees, and it may promote competition across value chains. It will also further balkanize our healthcare system. This bears watching. Taking stock. A basic tenet of business strategy is that high profit margins are an invitation for new firms to disrupt the market. Healthcare is a huge and hugely profitable business, so it is no surprise to see so many organizations joining the fray. While many may succeed at grabbing a piece of the pie, overall healthcare spending will only fall if these newcomers reduce the size of the pie. We are skeptical about many ongoing efforts. Consider the themes mentioned in this and other chapters: disruption, transformation, platforms, silver bullets, and gurus. These are quintessential examples of the types of BS that are commonly found in the healthcare industry. Point 47 Such BS may be covering up the main reasons for many of the strategies discussed here: rent-seeking and growth. This suggests that everyone should swallow all these would-be disruptors with a huge grain of salt. There is some cause for hope. We are seeing more new ideas for transforming the healthcare value chain than ever before, from a wider scope of players. The good news is that one success may be all that is required for radical change. Disruption of healthcare markets is a lot like venture capital in Silicon Valley. Nearly all venture capital bets fail. But occasionally a Google or Facebook comes along, and the venture capitalists make more than enough to cover their losses. While we are doubtful whether any of the efforts described in this chapter will prove to be the Google of healthcare reform, including Google itself, it is still early days for the disruptors. So fasten your seatbelt, as it could be a wild ride. 10. Recommendations for competition policy. Vigilant and effective antitrust enforcement today is